Hi, everyone. It looks like some folks are still connecting to audio. So I'm just going to wait maybe about a minute more before we get started. Just to let everyone know, I am recording this for the people who weren't able to make it. But just stay tuned for maybe about 30 more seconds and then we'll get started. Thanks for waiting. All right, it doesn't seem like anyone else is joining. So I'm happy to get started. Hi, everyone. Welcome to the first JBJS hosted journal club. I'm very excited that you all could join. This is, like I said, the first installment, but we're joined by folks from across the world, which is great. We got a lot of people in India, some folks in the States as well. So I know it's evening and morning for half of us. But I'd like to introduce myself. I'm Aiden Smith, the JBJS account manager. So you probably got a lot of emails from me. I'm really happy that you were able to join over Zoom. But I'm joined with Dr. Marc Swiontkowski. He's our editor-in-chief, and Matt Schmitz, our deputy editor. I'll let them talk about themselves in just a second, but I'm very excited that you all could join. We're going to go through some papers today and have some presentations by residents, sort of talk about some recent literature that JBJS has published, and hopefully have a good discussion about it. So I would say maximum this webinar will last for an hour, although we probably will run quicker. So with all of that, I'm just going to make sure everyone's muted. Feel free to unmute yourself if you have any questions. But I'm going to hand it off to Dr. Marc.
Well, thanks, Aiden, and welcome everybody to an experiment we're doing at JBJS. I am assuming that some of you on this call may have journal clubs at your home institution, but I'm also assuming that some of you may not, and that's really why we're seeing if this is of value to you. And Aiden, I'm assuming you're going to be sending out a survey afterwards so that our people who are dialed in will give us the feedback that this is worthwhile. So why do journal clubs? It's because the literature is constantly evolving. And we've certainly seen that with the COVID pandemic about how we get closer and closer to understanding the thing as the weeks roll by, and you have to really stay up with things. And certainly that's not any different than in orthopedic surgery. And what we all need to do is stay up with the literature and stay up with evidence-based practices. And it's important to be able to look at the experimental design of a manuscript and critically assess it, and then answer the question, should I change my practice based on what's published in this manuscript? And that's what this whole process is all about. And it's also why I've elected to ask Matt Schmitz, our deputy editor for social media, to kind of do an example for anybody on the call who may not have ever done a review for a journal club. Aiden sent out a little bit of a template, which is one that we use at the University of Minnesota and is used in other places and has been influenced by other editors in orthopedic journals. And you'll see that the last question is, should I change my practice based on this information? And that's where we'll end the discussion for every paper. So without further ado, Matt, maybe you could tell our audience exactly, I know where you are, but where do you practice and what your area of interest is? And I want to thank you for taking the time. Matt's actually away at one of his children's sports events and has kindly agreed to dial in. So Matt, take it away from here.
Thanks, Mark. Yeah, we've got some soccer going on, and I'm down in San Antonio at the San Antonio Military Medical Center. I am PEDS trained, and my interests are adolescent sports and then open and arthroscopic hip preservation. So we run these journal clubs with our residents as well. I think it's important to be able to consume, but also critically evaluate the literature, like Mark said. And one of the things I always look at with an article is can I believe this study? Does the data seem valid? What are the results showing? Or is there clinical significance or statistical significance? And then is there validity to it? So with that, we'll go into the first article, which is the shared decision-making is associated with better outcomes in patients with knee but not hip arthritis, the DECIDE OA randomized study. So it's important to know where the article is coming from. This is from Dr. Sapucha et al. From Mass General, Northeast Baptist, and Newton Wesley Hospital in the Boston area. And the basic premise behind the background is that the idea that patients who are engaged with the decision around whether or not to have surgery and their surgeon have more realistic expectations and are more likely to receive their preferred treatment. The DECIDE OA randomized trial is a multi-site comparative effectiveness trial that was measuring decision quality and then following patients with hip and knee arthritis over time to assess outcomes. The purpose of this specific study was to examine whether patients who made high quality decisions had better health outcomes, higher satisfaction, less decision regret compared to those who made lower quality outcomes. So the methods for this, it was a 2x2 factorial randomized study. And whenever I see, I'm not a stats guy, so whenever I see some of these, I take a step back and say, well, what is that? That's randomizing people to treatment either A or B with a further assignment to C or D within the group. So for this specific study, the surgeons were randomized to an intervention arm where they received a report of what the patient treatment preferences were or their usual care arm. And that report of patient preferences were the patient's main goal for the visit, 3 important activities that they want or need to do but can't, and what their actual preferred treatment was, surgery or non-op. The patients were then randomized to a decision aid that they received before their first surgical consultation versus no decision aid. The patients were assessed at that pre-op visit or before their first visit, 1 week post the visit, and then 6 months post the visit or post-surgery. Specifically, the outcomes they're looking at were the knee osteoarthritis decision quality instrument and hip osteoarthritis decision quality instrument, which this is a questionnaire that answers whether or not the patient was well informed about their decision. They had the EQ-5D, which is a general health outcome score. For the knee patients, they evaluated the KOOS, which is a valid and has been tested over and over again for knee outcomes, functional outcomes. For hip patients, they used the Harris hip score. Then they used a decision regret scale to judge whether or not the patients regretted their decision, and patient satisfaction, how they felt about their treatment, whether it was operative or not operative, and describe their current pain compared to their initial visit. So now, when you look at that, at the receiving the patients that received an intervention, so they received a decision aid. With that, they tested them and they could determine whether or not they made a quote unquote IPC, and that's an informed patient-centered decision. So if you made a decision and you understood what that decision was by scoring over a threshold, then you made an informed patient-centered decision. Alternatively, you made a non-informed patient decision, and that kind of fell into 3 categories: whether you were not well informed but matched to what your preferred treatment was, whether you were well informed but did not get your preferred treatment, and if you were not well informed and not get your preferred treatment. What they really looked at is they compared the patients that were informed, those that made IPC-based decisions, to those that were non-IPC. And so they had over 1,100 patients, 1,124 patients were enrolled, and 845 completed the follow-up. About 2/3 of these were in the informed group and 1/3 in the non-informed group. 283 of the hips, 75% of which were in the informed group, and 562 knees, 66% of which were in the informed group. What they found is that the informed patient-centered decisions, patients had slightly lower general health outcomes, the EQ-5D. They were more likely to be male. They're more likely to be hip patients, higher educated, white, non-Hispanic, and were more likely to review all of the assigned decisions aids. When they looked at the health outcomes, they showed that non-op patients and op patients made improvements in their generalized health outcomes in addition to their specific knee and hip outcome scores, but the operative patients obviously made much larger improvements. For the general health outcome, the EQ-5D, the informed patient-centered decisions showed larger increases compared with those who made low quality non-IPC decisions. And when they modified this, when they adjusted for surgical treatment, what they found out in the data is that the IPC decision-making was associated with improvement in knee symptom scores, but not in the modified Harris hip score. They then looked at satisfaction and patient regret at 6 months, and 55% of the patients reported being satisfied, 57% much better, and 44% with no regrets. And furthermore, patients who made an informed patient-centered decision were more likely to report better. Pain was much better. They were satisfied with their treatment, and there was no regret. However, these effects diminished after you adjusted for treatment. And for knee patients, those who made the informed decisions had significantly higher satisfaction, much better pain relief, and no regret, even after adjusting for that surgical treatment. The informed patient-centered decision did not appear to be a significant predictor for hip patient satisfaction or regrets. And so the take home from this is that we know that informed decision-making for our patients is a good thing. And this showed that it was specifically good with the outcomes for knee patients undergoing knee arthroplasty. It did not seem to predict better Harris hip scores or higher satisfaction and less regret in patients with hip OA. But there's some questions. Maybe we know that hip replacement surgery is one of the most successful surgeries we have in orthopedics. Those patients do routinely well and get better faster than total knee arthroplasty. And so one of the questions that comes out of this is maybe that interplay with the quick recovery then loses its effectiveness when you look 6 months down the road at informed versus non-informed decision. So, the take home, I think I can believe this study. I think the results are valid. We know that informed decision-making is better. I think that this needs to be studied further to say why specifically these knee arthroplasty patients, operative and non-operative, tend to do better than the hip patients. But I think this is a very well done study.
And the question, if you were an arthroplasty surgeon, would this impact your practice, Matt?
I think it would. I think that we're really moving towards our patients being well informed, and I think it's the right thing to do for our patients. Now, this study may not have shown that it improved their outcomes for the total hip patients, but maybe we're looking at some of the wrong outcome measures. And I think that an informed patient makes a better decision and is more in tune with their healthcare. And so I think it's a good decision to have for any type of surgery, is that you inform the patient and give them decision aids.
Well, that's a great review, and thanks. So one of the things that we do with journal clubs is whenever there's a member of the editorial board, we try to give you, the people that are participating, a little bit of a background as to how this manuscript got into the journal. As you may or may not know, we do double-blind review at JBJS, meaning that the authors do not know who's reviewing the paper and the reviewers don't know who the authors are. So we try to remove as much as we can the bias involved with the scientific review, and we always make sure that the people reviewing the manuscript are highly qualified. So the reason why this paper is being discussed tonight and did get published in the journal is that it's a very, very high quality level 1 study, a randomized controlled trial, which is the optimum methodology for limiting bias within a study. It is what we call an efficacy trial. So it had a lot of exclusions of patients that you could see in the consort diagram. So it makes it a small, perhaps ideal population to do a study, but it doesn't really answer the question as to whether or not this would work in a large scale arthroplasty practice as a routine measure. That should be done in a much larger trial in an effectiveness manner, where the outcomes are simpler and less involved. I would also point out that it's a very much a study done in North America, and there are cultural issues involved with the patient communication and doctor-patient interaction. So a study would have to be done wherever there are differences in nationality and in the local medical culture, et cetera. So feel free at any time if you put your hand up or put a comment in the field or ask a question in the chat. The last comment I'll make before we go to the first presenter is that these manuscripts were the most viewed in 2021 on the JBJS website, the most opened. So that's how they were selected for tonight. So Aidan, who's the next reviewer up?
Thanks, Matt, for the presentation. And thank you, Dr. Marc, for going through the selection process and why these papers were chosen. So I'm hoping we can go in order from the third article to the fourth to the fifth. unfortunately, we had one resident who was going to present wasn't able to, so we'll be skipping over the second paper, longitudinal changes in serum markers, bone metabolism and bone material strength in premenopausal women with distal radial fracture. I'm not a surgeon, so I'm relieved I managed to get through that title. Okay, but we're going to move on to the third paper, which will be presented by Dr. Vignesh from Savitha Medical College. I'm hoping that you have a presentation, is that right, Dr. Vignesh?
Yes, Mr. Smith.
Great, okay. So feel free to share your screen if you want to, and the stage is yours.
Just a minute, man.
No worries. So it might be helpful. I thought about doing this for Matt, for your presentation. For those who don't have a PowerPoint, maybe it would be helpful if I screen share and show the paper while we're doing this. I know that that's pretty typical for online journal clubs. Is that right, Mark?
That's exactly right, Aiden.
Okay, good. Yeah, I know when we're going through these papers, it's kind of weird to look at each other while we're talking about a paper. So for the others, I'll screen share so we can actually look through the paper while it's being discussed. Looks like he left the waiting room. I'm having him rejoin. If it takes a while to set up, we can move on to one of the next presentations and come back.
Sure, or I can also discuss one of the papers that is not being presented. Here we go. Looks like we're good.
Okay, great.
Good.
So you just want to make sure that he's not muted. Now you're off mute. Great.
Sorry. I am Dr. Arun Vignesh from India. I am an orthopedic resident from Savitha Medical College. The topic of my journal is a mini open approach to medial pinning in pediatric supracondylar humerus fracture is safer than previously thought. This article was published in JBJS in the month of January 2022. These esteemed doctors are the authors of this article. This is Dr. Gregory A. Mencio, who is a leading pediatric orthopedic surgeon in the States. The study was done in Monroe Carroll Jr. Children's Hospital at Vanderbilt University Medical Center, Nashville. Supracondylar humerus fracture is fixed using smooth pins. There are two methods. One is retrograde lateral pinning and another one is cross pinning. The lateral pinning is mostly preferred, but the cross pinning is better biomechanical stability. The major disadvantage of cross pinning is iatrogenic ulnar nerve injury. The current AOS guideline is to avoid the medial pin use. The methodology followed in the study is before medial pinning, we have to check the ulnar nerve instability in the contralateral elbow. Then the injured arm is placed in external rotation with elbow flexed 50 to 60 degrees. Then 1 centimeter incision is made over or just anterior to the medial epicondyle. Then dissection is done till flexor pronator mass origin. Then if the nerve is found to be unstable, we should do pinning with the elbow flexed at less than or equal to 45-degree flexion. After adequate dissection, we have to palpate the borders of medial epicondyle using the pin and check under fluoroscopy. The pin is placed either through medial epicondyle or tendon of flexor pronator mass. Then closure of mini open wound and pin bending is done. Then we have to immobilize the cast or splint with elbow flexed at less than 80 degrees. Medial pinning can be done by two methods. One is blind palpation and percutaneous pinning. Another one is direct visualization using mini open technique. There are two types of iatrogenic ulnar nerve injury. One is direct violation of ulnar nerve by the pin. Another one is ulnar nerve symptoms which are caused by pin irritation or compression. It is a retrospective chart and imaging review study. The level of evidence is 4, and it was conducted from the study was conducted from November 2007 to October 2017. Is mini open technique for medial pinning in pediatric supracondylar humerus fracture safe? Is a primary research question. Is the rate of iatrogenic ulnar nerve injury due to cross pinning more when compared to iatrogenic nerve injury due to lateral pinning alone? Is the secondary research question. The outcomes measured in the study were loss of fixation, reoperation rate, fracture union, osteonecrosis, pin tract and deep infection, iatrogenic ulnar nerve injury. A total of 1,625 patients, pediatric patients, sustained supracondylar humerus fracture, of which 927 underwent lateral pinning, 698 patients underwent cross pinning. Of the 698 patients, only 3 patients had iatrogenic ulnar nerve injury in this study. These are the following complications rate seen during the study. The loss of fixation was 1.9%, and iatrogenic nerve injury rate was 0.4%, and the reoperation rate was 22% in this study. The patient 1 had Gotland 3A type of fracture. The violation of nerve was seen intraoperatively, and the patient had motor and sensory symptoms. The patient did not have full resolution of symptoms. The patient, at the last follow-up, patient had mild weakness and paresthesia in the 5th digit, and the patient needed physical therapy, occupational therapy, and bracing. Patient 2 had Gotland 3B type of fracture. At 3 weeks post-operatively, patient presented with only symptoms of sensory, with pain with active motion of the digit, and the patient had full resolution of symptoms at 8 weeks. Patient 3 had flexion type of injury. At 1 week post-operative period, the patient presented with weakness with clawing of 4th and 5th digit. There was full resolution of symptoms at 22 weeks. The conclusion of the study is the mini open technique is a safe method for medial pinning in supracondylar humerus fracture. Iatrogenic ulnar nerve injury in this study was 10 times lower when compared to previous studies, and it was also lower than the estimated iatrogenic nerve injury seen during lateral pinning. The risk of long-term ulnar nerve injury in cross pinning in this study was only 0.1%. The results, conclusions were sufficiently supported by these results, and the strength of the study are: it had large sample size with longer follow-up. Since a single approach was used in all patients, it had reproducible results. The weakness of the studies are: it is a retrospective study which was done only at a single center, and it did not have proper documentation regarding the entry of medial pin placement. Since it was a retrospective study, there was mild ulnar nerve symptoms may be missed or may not be documented properly. The take-home message from this article is: internal rotation stress test is done to determine the medial column stability after lateral pinning. If the test is positive, we can do medial pinning. Medial pin can be used as an alternative to third lateral pin, or it is preferred as a fourth pin. Mini open technique is safer method for medial pinning. I would like to thank the JBJS team and faculties of my department for giving me this wonderful opportunity. Thank you.
That was a simply outstanding presentation. You went above and beyond preparing the PowerPoint and hit all of the important things. So let me ask you the question: will this manuscript change your practice?
Yes, sir, definitely, sir. If the medial pinning is safer, we can go for a cross pinning more frequently. This internal rotation stress test gives us a measure to determine the medial column stability, which might be needed to fix the fracture.
Yeah, I agree. I think that is how this manuscript should influence the practice. But you pointed out the weaknesses very well. And the reason why this got into the journal is it's a very large series, appropriately statistical methodology that's appropriate for this retrospective design was used, and very, very clearly presented. And it really does point to a clinically applicable conclusion about the internal rotation stress test. And I think it will influence care. Ideally, we would have a multi-center randomized trial to do this. And I'm a big advocate of randomized trials. However, doing randomized trials in children is even more difficult than doing surgical trials in adults. And Matt, as somebody with pediatric experience, I think you would agree with that statement. It's very, very hard to get parents to randomize.
It is, and I think this is a great example how even it's a quote unquote level 4 study, it's very well done and it brings across a message. You know, this kind of came out of the fact that some of the AAOS CPGs suggested that we should shy away from medial pinning, but there are situations where it's needed and you simply need to use a medial pin. And this shows that it can be done safely through a mini open technique. So I applaud the authors for their work on putting 10 years of data together.
Yeah, so for those of you on the call who may not be familiar with the CPGs, those are clinical practice guidelines that are organized by the American Academy of Orthopedic Surgeons with panels of experts looking at all of the published literature, and then they come up with a written document that should guide practice. The issue is that they're looking at literature that was previously published, and there's always literature coming out, so it's not continuously updated. So we even think that by the time it's published, it's outdated. So this is a manuscript that will definitely influence the next iteration of that clinical practice guideline. And wouldn't it be great if we had a instantaneous way to do updates of clinical guidelines like this? The journal is working on that. Matt, do you have any other comments for this outstanding resident presentation?
No, I thought he did a great job.
Yeah, first class. Okay, Aiden, who's up next?
Thanks, Dr. Vinesh, for that presentation. We're going to move on to the fourth paper here. I believe Dr. Paul Ritz from the University of Florida is going to present it for us. Paul, thanks for joining. Do you want me to share my screen and show the paper? Would that be helpful?
Sure, I think that'll be good.
Okay.
Can everybody hear me? I'm kind of trialing some new headphones here.
No,
awesome.
Great.
Love it. So yeah, anyway, Paul Risk, PGY4 at University of Florida. Thanks everybody for joining. I did not prepare a PowerPoint, but I'll be talking about
that's
lymphedema.
Perfectly fine. We don't expect that.
Totally fair. Lymphedema is a significant risk factor for failure after a primary total hip arthroplasty. And this was done out of the Mayo Clinic. Some big names on the paper, Dr. Llewellyn, of course, being the senior author who well known in the arthroplasty world for a lot of his research and development in trabecular metal, which is a big mainstay in arthroplasty. But moving on to kind of talking about the paper, we'll just jump in. It was a retrospective case control comparison. It was a level 3 study. And they ultimately went back from 1998 to 2016 and were able to get 83 patients who had a primary total hip who had the diagnosis of lymphedema. 57 of them were female, 25 were male. For their control group, they matched these patients in a 1:6 ratio and matched them by demographics. Their primary and secondary study questions that they were looking for was whether or not lymphedema increased the risk of infection or related complications, increased their risk of reoperation, and they ultimately wanted to look at outcomes of patients who had lymphedema in the ipsilateral extremity after a total hip arthroplasty. So looking at their outcome measures, they looked at revision total hip arthroplasty as one of the outcomes, and they defined that as any surgery that involved removal of hardware. They looked at infection, and then they had a subdivision there looking at superficial infection, which they defined as drainage or delayed healing. And then the deep infection they defined by MSIS criteria. For other complications, they looked at fracture, wound healing, any sort of dehiscence, any sort of medical comorbidity or a complication like DVT, PE, or dislocation. And then they also took all of those separate types of complications and grouped them as related to lymphedema or not related to lymphedema. Their analysis that they used was a 2-sample t-test for the continuous variables, and then a Fisher-Exact test for binary variables. For looking at the survivorship free of infection and reoperation or revision, they used Kaplan-Meier curves for survivorship. And then they were able to use univariate regression for patient factors and time to event. They did not use multivariate analysis just because there were so few number of events. In terms of the results, they did find that lymphedema had an increased risk of overall number of complications. They had a hazard ratio of about 4, but only those related to the actual complications known for their relationship to lymphedema. If they split it up and looked at the non-lymphedema complications, the hazard ratio was only about 1.2. Reoperation rate was higher in patients who had had lymphedema, and that was about 3.16. And then they also had a higher revision rate at 10 years, with patients who had had lymphedema having a 89% survivorship versus 97% survivorship in patients who did not have lymphedema. The other thing that they also looked at through all of their different evaluations was whether or not the surgical year impacted the outcomes, because it was such a large period for the study. They looked at up until 2008 and then after 2008 to kind of get a good idea and see if practice change or any other sort of a variable might have had an impact. In all of their analyses, it did not. Also looking at infection, lymphedema patients had worse 5-year survival for infection. They had about a 90% survival rate, whereas non-lymphedema patients had a 97% survivorship, the overall hazard ratio of any infection being about 4.5. They did have more deep infections in lymphedema patients, with a odds ratio versus a superficial infection being about 7.7. And the range of infections, specifically the deep infections in lymphedema patients, happened over a greater range. So they happened earlier. I think one was as soon as either 1 or 3 months, but also happened much later too. So the range was much greater and had to be something in clinician's mind with a lymphedema patient compared with a non-lymphedema patient. Interestingly, all of the infections that they kind of looked into were all polymicrobial, whether it was superficial, deep, lymphedema, or non-lymphedema patient. This was a stronger predictor whenever they also compared this with BMI, which is a obviously well-documented and understood risk of infection in total hip arthroplasty. So kind of looking into the analysis, is the conclusion supported by the results? Yeah, definitely. There are higher risks of complications and infection in patients who have ipsilateral lymphedema. And looking into some of the strengths, it was a matched cohort with a 1:6 ratio. So kind of taking the relatively low incidence of lymphedema in total hip arthroplasty patients and trying to tease out some of these relationships with statistical power. And then they had a pretty large review patient period. So they were able to get a number of patients, and the division along their time period was helpful in making sure there wasn't any specific temporal effect that was leading to maybe some outcomes or conclusions that were faulty. In terms of weaknesses, there were still relatively few events, and statistically that can confound things, although the results that were shown are pretty convincing. It is a retrospective study. And the only other thing that I could think of that could be potentially more helpful or a little bit more granular in detail, although actual application would be difficult, is looking at the grading of lymphedema, because lymphedema can be relatively severe or relatively benign, for example, if it just improves with elevation. And that's not something that they reported on in the paper, which would be, I think, very difficult to elucidate from a patient back in the 90s just over chart review. Ultimately, I think this will change my practice and just paying closer attention to patients with lymphedema. And if we do ultimately proceed with surgery while they have moderate to severe symptoms of lymphedema, counseling the patient as to the increased risk that they have for complications and infection.
Well, Paul, another absolutely outstanding review. I have zero to criticize. Just outstanding, hitting the high points. I think the attention to the temporal issues is always important when you have a low incident condition. And one might ask, well, you know, this is it's not a randomized control trial. It's not a higher level design, but when you have such an uncommon diagnosis. We're just never going to be able to do that, even if you had multiple centers around the United States. Doing randomized trials on low events is really difficult. So JBJS publishes levels of evidence all the way from 4 up, and you saw an earlier one on 4, all the way up to the level 1, and we will always do that, and that's because orthopedics is such a very broad field. I like to point out when trying to educate administrators of institutions that orthopedic surgeons are 3% of the doctors, yet we have 40% of the CPT codes, which kind of gets their attention. And that's absolutely true. That shows the breadth of our field, from peds to spine to joints to trauma. We have a very broad field and treat many conditions that are very low incidence, particularly in peds and in tumor. So we're always going to have these experimental designs. One thing I will point out, I do think this case matching was absolutely the best way to do it. The way that I think could have been improved is when you're having 6 patients that you're matching to one thing you can do is randomly select the patients you match. They didn't do that. It's a very minor point. But you can use a random table generator to select the patient you match to the case incident. Very minor critique, and obviously that's why this appeared in the journal. Any comments, Matt? Not your area, or actually my area of expertise. I've only seen a handful of patients with this diagnosis in 35 years or longer of practice. So any comments?
No, I think it's a good study for a rare diagnosis that shows that there's clear outcome differences. So again, you can use that to help counsel your potential patient should you come across someone with lymphedema. Yeah.
And the polymicrobial infection, I think, really educates us that it's because the integument is not intact. The barrier to the external world is just not intact when you have such fluid-bathed wound edges that you can't get early healing. Good. Are there any other questions from anybody on the call who would like to ask one or put it in the chat? Not seeing any. So okay, Dr. Ashraf, do you want to just unmute? Maybe Aiden can help you do that. Okay, okay, yeah, I've got it now. Yeah. Oh, right, that's an excellent question. So what's the issue when a paper is published 4 or 5 years after it's actually concluded? This is a very interesting thing, and it's hard for me not to go off on some philosophical discussion, but most often what this is the person who's completed the research work knows the answer and incorporates the findings in their practice. The hardest thing to do is to sit down and write a manuscript and then deal with journals like ours. We're going to ask you a bunch of questions to clarify it and deal with reviewers. It is not a fun practice. It's not a fun thing to do. And that's why so many manuscripts sit on people's desks for years. If it's too long and the field has moved on for a common condition, it can really impact the clinical utility. And we have rejected papers on that basis, again, for very common conditions. But the fact of the matter is, it's way more fun in our field to go to the OR or the clinic and see patients and do surgery than it is to sit down and slog out a manuscript and then have to deal with reviewers and editors like me. That's my take on the whole process. One of the things that all of us in academic orthopedics struggle with, for sure. Excellent question. Okay, Aiden, do we have one more presenter?
We do have one more presenter for the final paper. We have Dr. Ren Kumar from Savitha Medical College, also in India. Feel free to share your screen. If not, I'm happy to share mine and show the article. Would you prefer if I share the article from my screen?
I do have a presentation. Let me just see if it's actually working over here.
Okay.
Is it visible?
Yes.
Yep. Yep. We can
Thank
see it.
you.
Okay, thank you. Good evening, everyone. I'm Dr. Just give me 1 second. I'm Dr. Saidar Kumar. I'm an orthopedic resident from Savitha Medical College and Hospital from India. Thank you for giving me this opportunity. So I'm going to be speaking on the article of the functional outcomes of arthroscopic acetabular labral repair with and without bone marrow aspirate concentrate. So this study was done by a team headed by Dr. Scott Martin, who was the director for the Joint Preservation Service and also a sports medicine fellowship program. And he's also an associate professor of orthopedic surgery at Harvard Medical School, apart from being a sports consultant for multiple sporting teams. So the study was done since osteoarthritis of the hip, it is associated with not so good outcomes when it is treated with hip arthroscopic acetabular labral repair. So in order to minimize the progression of the cartilage damage, bone marrow aspirate concentrate application was suggested as an adjuvant therapy. And the study was a prospective study for collection of the data, and it was compared with a similar control group, and the level of evidence was 3. So the outcomes measured in the study were which was of significance for the patient-reported outcome measurements between the bone marrow aspirate application groups and also the control groups. They were measured with 3 questionnaires, which was the International Hip Outcome Tool 33, and also the Hip Outcome Score Activities of Daily Living subscale, and also the Hip Outcome Score Sports subscale. There was a multivariate regression done for the patient-reported outcome measurements at the time of enrollment and the 3rd, 6th, 12th, and 24 months of follow-up. So in the results, the outcomes, they were more or less similar between the BMAC and the non-BMAC groups. And upon doing a further subset analysis among patients who had grade 2 and grade 3 alone, it was found that the BMAC and the non-BMAC show differences, with the BMAC scores actually having more improvements, indicating that the BMAC was actually helpful in the patient's recovery. So as we can see here, this is the table for the patients who are having only grade 2 or grade 3. The BMAC being on the left side and the non-BMAC being on the right side. As we can see, that's a significant improvement for the patients who had the bone marrow aspirate concentrate application. And the results were statistically significant also. So this is a graph which shows the study between the BMAC and the non-BMAC groups across all grades of grade 1, 2, 3, and 4. So as we can see over here, there is not much of a difference between the 2 groups. But when we take the patients who had grade 2 or grade 3 alone, we can see a significant difference in the outcomes of such patients. So in conclusion, patients with moderate cartilage injury, that is of outerbridge grade 2 or 3 and 3, they had arthroscopic acetabular labral repair with BMAC application. They showed greater functional improvements at the 3rd, 6th, 12th, and 24 months of follow-up when compared with those patients who also underwent the similar procedure without the BMAC application. And also the patients experienced no adverse effects for the additional procedure. And the strengths of the study were, it did have a large sample size, and it also had a similar control cohort. And they also mitigated the expert bias. And multivariate regression was done for the variables, and there was no socioeconomic differences since it was sponsored by private philanthropic organization with no connections to any industries. And the weaknesses were, it was a midterm follow-up study, and it was not a randomized control trial. And there was also a possible effect of a placebo since the patients were aware that they were receiving the bone marrow aspect concentrate. So can it be practiced right now? I don't think so, since it needs a long-term follow-up for seeing if there are any further adverse effects which might be seen. And it's also not a randomized control trial, so a further randomized control trial might be needed for us to impart this in practice from here onwards. So I would like to thank everyone for this wonderful opportunity, and also people at my department. Thank you very much.
Another great presentation. Thank you for putting the time in to review this article. Matt, this is kind of in your wheelhouse. What comments do you have about how this should influence practice?
Yeah, I think that this is a really interesting concept. I think that it shouldn't necessarily influence your practice yet, but gives good ideas for future study designs. I think some highlights from this is that here in the States, BMAC can be an expensive endeavor, and this was all done through a philanthropic fund. And so you don't want to get into the situation where only patients that can pay for a certain treatment can potentially receive the benefits. So that's a strength to this paper. But it kind of goes back to the whole point of hip preservation. What we've seen in multiple studies is that patient selection is absolutely paramount. And maybe this is something in that group that has some early arthritis that many of us would argue probably shouldn't be having hip scopes. Is there going to be a role in the future for BMAC? Maybe. So I'm not jumping on the bandwagon yet, but it does give some ideas to some potential future studies to see exactly how those differences bear out.
Thank you. And one of the real weaknesses of the study is the fact that the patients were not blinded to treatment group, which is unfortunate. That would have really strengthened the conclusions, and that was pointed out in the report. And a very, very, very important point is when you don't have the ability to do a randomization and you're doing retrospective studies like this, it is very, very important to try to blind the outcomes assessors and blind the patients whenever possible. It creates issues with informed consent, but it's really, really worth it if you can spend the time to explain to the patient that you really do not know whether or not this additional treatment element is going to be helpful or not. It takes a long time, but if you're willing to spend the time and get the patient to understand that they are helping future patients by participating in this, in my experience is they will generally agree, certainly more often than not. So Aidan, we don't have any more papers scheduled to be discussed, correct?
We don't. There was just that one remaining paper that we had that wasn't able to be presented.
And which one was that?
That was the one.
The distal radius?
Correct.
Yeah, can you just pull it up and maybe I'll just make a few comments in closing. And
sure. Let me just share my screen. Here we go.
Yeah, so this study again from Boston in a different institution looked at the multiple serum bone markers that are metabolic markers of bone remodeling, and looked at bone material strength as a correlation. It is a study done with a broad range of biochemical indicators. And can you scroll down just a little bit more, Aidan? And this is a center where they have been interested in fragility fractures for decades, going back to the 80s and 90s. A very experienced research team. And they looked at the various markers and identified a couple of markers that may be important to look at risk going forward. So this is sort of a cutting edge kind of a paper. It's a paper with a small sample size, looking at a broad range of expensive metabolic markers, just looking at a glimpse of what the future might be in terms of screening patients for treatments for osteoporosis to try to limit fracture risk. So a kind of a cutting edge basic science, clinical science type of approach. And that's why this one was selected. Very well done. So if there are no further comments or questions, I'm going to give everybody a chance to put something in the chat if they wish, or raise their hand. Not seeing anything. Well, Matt, I want to thank you again for taking the time on the road there away from your family to participate. Your comments were greatly appreciated by the participants and by me, particularly with that last paper. So thanks very much. And Aiden, thanks for organizing this. And thank you, participants, particularly those that presented, those that listened. We really want to know if you found this valuable. Is it worth an hour of your time to listen in? Is it worth more than an hour of your time to prepare a presentation? And give us some feedback, and we'll decide whether or not we should do this again. Thanks, everybody. Have a great night or a great day, depending on where you are around the globe. We appreciate it here at JBJS.
Thanks everybody.
Yeah. Bye-bye.
Thanks, everyone. Bye-bye.
Thank you.
Thanks, everybody.